denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout était autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possono pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm a critical care nurse. I'm proud to work together with other professions as a multidisciplinary team to fight COVID-19. Together, we are intensive care.
I am an anesthesiologist and I'm proud to be an intensivist. Together we are fighting COVID-19. Together we are intensive care medicine.
I am a critical care nurse and perfusionist. I am proud to work in an intensive care unit. We are working together to fight COVID-19 and together we are intensive care medicine.
I am an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Good afternoon, everyone. My name is Daniel Talmor from Boston, and together with my colleague Lise Picot from Lausanne, I'll be hosting this webinar. Our topic today is mechanical ventilation in acute hypoxic respiratory failure, and it's hard to think of a more relevant topic this year. So we will get right on with our speakers today. We're fortunate to have three excellent experts in the field. And Lise, will you please introduce our first speaker?
Good afternoon, everyone. It's my pleasure to introduce Professor Guillaume Carteau. Guillaume works in Paris-Créteil, France, as an intensivist, a teacher, and a researcher. He takes care of a lot of COVID and non-COVID ARDS patients, and is going to discuss a very important topic, which is balancing non-invasive ventilation strategies with early intubation, understanding the challenge.
Thank you very much, Liz, for this nice introduction. Is it okay? Do you hear me well? Okay, I guess you hear me. And okay, you see my screen as well? Okay, so thank you very much for this nice introduction, and thank you to the scientific committee for the invitation. This is a pleasure to participate in this very exciting webinar. So we will discuss a highly debated topic, especially during the pandemic, but I will not discuss about COVID-19 that much, because I think we have to consider the question globally for acute hypoxemic respiratory failure. So let's try to understand the challenge of balancing non-invasive ventilation strategies with early intubation. Here are my conflicts of interest. So potential benefits of non-invasive strategies are obvious, and they had been well demonstrated in patients with acute exacerbation of chronic respiratory or cardiac diseases. The use of NIV in this population was associated with less nosocomial infection and a drastic decrease in mortality. And the good news was that when NIV failed, the prognosis remained the same than comparable patients who were intubated first. But the picture was, however, very different for acute hypoxemic respiratory failure. In these patients, when NIV was a success, its use greatly reduced the risk of death. But when NIV failed, the risk of death increased as compared to patients intubated first. And that was a problem because the intubation rate observed in early series of patients with acute hypoxemic respiratory failure was quite high, around 30–40%. And unfortunately, this is already true. In the LungSafe study, the intubation rate reported in ARDS patients receiving NIV was 37.5%. And once again, in case of NIV success, the mortality was low, but mortality was particularly high in case of NIV failure. And whether this high mortality reflects a selection of the most severe patients or whether it reflects a deleterious effect of the non-invasive strategy is the key question. Invasive mechanical ventilation in these patients may allow tailoring lung protective ventilation with low tidal volume, higher PEEP, easier prone positioning, and careful respiratory monitoring. So, are there situations in which the beneficial effects of non-invasive strategies could be offset by some deleterious effects, such as non-protective ventilation? This leads us to the concept of PSIVI. Everybody is familiar with the concept of VD, of ventilator-induced lung injury. The concept of patient self-inflicted lung injury means that the lung injury could be generated or aggravated by the spontaneous respiratory effort of the patient himself. In that case, invasive control ventilation could be the solution. So let's go through this. Using the concept of VD, we've learned the different mechanisms that may impair the lung under mechanical ventilation, and the main one is overdistension. But from a mechanical standpoint, it doesn't matter whether the distending pressure of the lung, the transpulmonary pressure, is mainly due to the positive airway pressure or to the negative pleural pressure due to muscle pressure. The result is the same. The deformation is the same. The distension is the same. So the consequences might be the same. Actually, this has already been demonstrated 30 years ago in this seminal experimental study from Didier Dreyfus. In this study, the authors showed that in rats, high tidal volumes generated by either positive pressure ventilation the amount of extravascular or lung water. The negative pressure of ventilation, by the way, mimics spontaneous breathing. And such a lung injury did not happen in case of high airway pressure, but low tidal volume due to the strapping of the rat's chest wall. I hope you enjoy my drawings, by the way. And so overdistension may arise during non-invasive strategies and represents the most straightforward mechanism of PSIDI. In this observational study involving patients with de novo acute hypoxemic respiratory failure, we showed that it was practically impossible to obtain a protective tidal volume, here in green, under non-invasive ventilation, and that a high tidal volume above 9.5 milliliter per kilo of predicted body weight was highly predictive of NIV failure. But there are also specific pathophysiological effects of spontaneous inspiratory effort, mainly due to the associated negative swings in pleural pressure. For instance, the Pendeluft phenomenon. So what is this famous Pendeluft phenomenon? In this experiment, a pig with lung injury is spontaneously breathing on the left panel under assist pressure control ventilation. These four curves represent variations of lung aeration of four areas following an antero-posterior gradient and obtained using electrical impedance tomography. Above, there is the esophageal pressure and the airway pressure. You can observe that at the very onset of the inspiratory effort, meaning at the onset of the negative swing in pleural pressure, there is an abrupt loss of aeration in the anterior non-dependent areas and a concomitant increase in aeration in the posterior dependent regions. This suggests an intrapulmonary transfer of gas from the anterior regions to the posterior ones. This phenomenon, called Pendeluft, disappears when the pig is paralyzed and ventilated under pressure-controlled ventilation. Anyway, if you wanted to reproduce during passive conditions the deformation observed in the posterior areas during spontaneous breathing, you would need to apply a very high driving pressure above 25 centimeters of water. That would lead to a tidal volume higher than 12 milliliters per kilo. And this is the kind of stress that is applied to the dependent areas during spontaneous breathing in this model of lung injury. Another phenomenon related to spontaneous breathing that we could discuss is the decrease in alveolar pressure that is suspected to be prone to promote alveolar edema, for instance, by increasing transvascular pressure. So all of these mechanisms may explain why experimentally a strong inspiratory effort occurring during severe lung injury is associated with worsening of lung injury. In case of mild lung injury, however, such aggravation was not observed. So I think it is important to keep in mind that this phenomenon of PSIDI, of potential PSIDI, has been mainly described when an abnormally strong inspiratory effort is imposed to severe lung injury. It is also important to notice that this concept is still highly debated, even among top-ranking experts. For instance, during the pandemic, Luciano Gattinoni proposed to monitor patients under non-invasive strategies with esophageal catheter and to prompt intubation as soon as esophageal pressure swings reflected a relatively high respiratory effort. And in response, Martin Tobin wrote that the existence of PSIDI had yet to be exposed to the acid wash of experimental testing, casting doubt on the very existence of the PSIDI. Anyway, having that said, how balancing non-invasive ventilation strategy with early intubation? First, I would suggest focusing on patient selection and being very careful with the most severe patients, such as those with very low PNF ratio, for instance. Second, I would suggest to choose the non-invasive ventilatory support because indeed, as you know, there are many different non-invasive ventilatory supports: oxygen therapy, high-flow nasal cannula, non-invasive ventilation, CPAP using a ventilator or some devices like the Bousignac valve, helmet NIV, helmet CPAP, and each one has its own physiological effect, which may be accompanied by its own risk of PSIDI. I will not discuss this further as this is the topic of the next presentation. However, I just wanted to make an aside to say that under conditions of a massive influx of patients, such as during a massive outbreak, like the COVID-19, the reasoning is completely different, and we must therefore be very careful when reading the COVID literature on these subjects. I will take the French example. In this example, you have here the French epidemiological data. You have the number of patients hospitalized in ICU over time, and the red line represents the total number of ICU beds usually available in France. So you can see that the total number of patients requiring ICU had far exceeded the usual capacity. So as in many countries, we set up intermediate care units to spare ICU beds. And these intermediate care units worked with non-ICU doctors and nurses and with non-invasive ventilatory support without ventilator, because all of the ventilators were put in the ICU for the intubated patients. So in Italy, for instance, there had been an important use of helmet CPAP. In our area in France, we rather used the Boussignac CPAP, on which we inserted a filter, a heat and moisture exchanger, in order to avoid viral aerosolization. So we assessed the mechanical effect of the filter on a bench model. Then we shot a video tutorial to teach to non-ICU healthcare workers how to set up and install a Boussignac CPAP with the filter in a COVID-19 patient. This video was made available in a massive open online course. Thus, in our center, within 1 month, 85 full code patients were treated with the Boussignac CPAP out of the ICU. And this strategy has allowed us to avoid some ICU admissions for some patients and save time for others. But this reasoning is very different from the reasoning about the non-invasive strategy for a COVID patient with acute hypoxemic respiratory failure into the ICU during the normal life. So I think we have to be careful with the recent literature about COVID and acute hypoxemic respiratory failure and non-invasive ventilatory support. Okay, the next step is to assess the risk of failure and the risk of too late intubation. So as soon as a non-invasive support is initiated, continuous monitoring of the respiratory signs of an under treatment is a very important point. And so depending on the ventilatory support, some indexes or parameters can be helpful to predict failure. For example, under NIV, the evolution of the PNF ratio, the monitoring of the expired tidal volume, or the calculation of the HACOR score can be informative. The HACOR score, for those who don't know it, is a score that combines several parameters such as respiratory rate, pH, PNF ratio, Glasgow scale, or under high flow nasal cannula, the calculation of the ROX index can help predicting failure or success. When the ROX index remains high, this is highly predictive of success, and conversely, when it remains low, it is highly predictive of failure. So we discussed the risk of CD, potential implications for patient selection of non-invasive ventilatory support, and the need for careful patient monitoring. But in conclusion, it can be said that we have raised more questions than answers, and there is therefore an urgent need for clinical research in this area, especially to date. There is no clinical trial assessing different intubation strategies, early versus late, in patients at high risk of PCD. I think this topic will be covered in the last presentation, so I'll leave it at that, and I hope that my presentation will be a nice introduction for the two next ones, and I thank you very much for your attention.
Thanks a lot, Guillaume, for this very good presentation. We are going to discuss several points at the end of the session. And for the participants, you can already ask your questions in the chat system if you want, and we are going to answer them later.
Excellent. So thank you very much for that talk. Great introduction. Our next speaker is a man who really needs no introduction. Antonio Pezzenti is one of the godfathers of critical care medicine and of the treatment of respiratory failure. He's the chief of anesthesia and critical care at the University of Milan, highly published author in the area, and a true expert. So Antonio will be speaking to us on the physiology of non-invasive ventilation. Antonio?
Thank you. I'm very happy to be here. I hope you see my slide. And you, great. So this is my title. These are my conflicts of interest, which really do not affect this speech. Just to go back to basic, it's very important to keep in mind, if we start from high flow nasal cannula, that high flow nasal cannula indeed is not a lot of oxygen. You can have any FiO2, and as a matter of fact, it's called high flow and not high flow oxygen flow. So you can have any FiO2. And first of all, when we apply high flow nasal cannulas, or high flows, let's call it this way, when we apply high flows, we see that PO2 FiO2 ratio increases and the respiratory rate decreases. This is the most common observation in acute hypoxemic respiratory failure. And there are data on COPD patients too, showing that the work of breathing decreases when we apply high flow nasal cannulas. And this effort to breathe is measured with different parameters like pressure time product or pressure swing. And the same has been observed in our hands in acute hypoxemic respiratory failure by measuring pressure time product and pressure swing too. And the results are exactly the same. The inspiratory effort decreases. High flow nasal cannulas decrease the inspiratory effort and therefore the comfort of the patient. High flow nasal cannula, probably by mechanical effect of the high flow, generates a certain level of PEEP. And according to the flow, we can go from 2 to 5 centimeters of water PEEP. With mouth open, the PEEP is much lower. When the mouth is closed, we can reach indeed up to 4 or 5 centimeters of water PEEP. And that might be at play in increasing PO2 FiO2 ratio. Something that was not expected, at least was not expected from me, was that high flow nasal cannulas contributes to CO2 elimination or to improve CO2 elimination. You see here a krypton gas scintigraphy. Krypton is a gas that Superman was coming, the planet where Superman was coming from. And as a matter of fact, krypton, you can do scintigraphy with krypton, and you can see it with high flow nasal cannula. The upper airways are cleared as opposed to controlled. And the same happens with CO2. If you measure CO2 concentration in the upper airways, you see that with high flow nasal cannulas, the dead space decreases, at least in healthy volunteers. Moreover, when we use high flow, if we measure the homogeneity of the tidal volume distribution, we see that the tidal volume distribution becomes more homogeneous with high flow nasal cannula as compared to Venturi. Probably, I guess, because the inspiratory flow decreases. And these are data that have been repeated many times by using electrical impedance tomography. Now, let's talk a little bit about CPAP and specifically about helmet CPAP or mask CPAP. The concepts are the same. But I'll be talking about helmet CPAP because in Italy, helmet CPAP is very popular. But we use also a lot of the French mask generating and valve generating PEEP, the name of which I unfortunately do not remember. But the flow of fresh gas flow at different FiO2s goes to the helmet and goes out to the atmosphere through a valve. If you have an infectious patient, like a COVID-19 patient, you can put a filter at the exit to avoid contamination of the ambient. And the valve generates a PEEP level according to what you need, actually what your patient needs. Helmet CPAP improves oxygenation as well. You can see that from spontaneous breathing, when we apply CPAP, PO2 FiO2 ratio goes up. With PSI, that is with an intermittently increased PEEP, we go up again. And the point is that when you tailor PEEP, the closer to get to the best PEEP, the higher the PO2 FiO2 ratio. And the effect of PEEP, we all know, is an increase in end expiratory lung volume. Many years ago, we measured that, and we could show that with the CPAP, the end expiratory lung volume goes up according to PEEP. Now, high-flow nasal cannulas are very effective in improving PO2 FiO2 ratio. They increase CO2 elimination. We tried experimentally to combine high-flow nasal cannulas with helmet CPAP. That is, the head of the patient was put into the helmet while he was wearing the high-flow nasal cannulas. The results were very interesting because obviously we could apply any level of PEEP. This was any level of PEEP allowed by the helmet. The experiment was conducted between 3 and 8 centimeters of water PEEP very effectively. And as you can see, we could avoid one of the major setback of a helmet, that is rebreathing and increase in inspired PCO2. Because the high flow washes the CO2 from the airways, and as you can see here, the inspired PCO2 is very low with high flow nasal cannula alone, is higher with the helmet, up to 3-4 millimeters of mercury, but goes down lower than 1 if you combine high flow nasal cannulas and helmet. Next, we have face masks and non-invasive ventilation. That is most of the time pressure support. And here, the first consideration is about interfaces, but we do not have time to discuss that. There are many kinds of interfaces. The helmet is probably the most tolerable interface, but it has a very high compliance. It sometimes is very difficult to do. Many times, it's very difficult to do good pressure support with helmet CPAP. But there is no doubt that in many occasions, face mask, non-invasive ventilation improves oxygenation. And the effect on PO2 and FiO2 is mostly due to PEEP rather than to the inspiratory support. As you can see here, the pressure support, when pressure support is 10 and PEEP 10, PO2 and FiO2 is 206, while if pressure support is 15 and PEEP is 5, PO2 and FiO2 ratio goes down to 153. That strictly suggests that the major determinant of PO2 and FiO2 is not so much the level of support, but the right level of PEEP. But the major and probably most effective gain of non-invasive ventilation is obviously that it decreases the work of breathing. And in patients with decreased compliance on acute hypoxemic respiratory failure, decreasing the work of breathing might be a major component of success. By decrease, the work of breathing is decreased by increasing the airway pressure. Increasing the airway pressure increases the tidal volume, and that increases the lung stress and possibly increases the risk of ventilator-induced lung injury. This slide is one of the most famous slides from recently in the last 5 years appearing, and this is the percentage of NIV failure in acute hypoxemic respiratory failure, and failure is much more common in patients with high tidal volumes than when compared to patients with low tidal volumes. And there is something we should keep in mind. This is again from Carto, that just spoke before me, and it compares NIV successes with NIV failure, but we are not interested in NIV successes and NIV failure. But rather on these. These patients were ventilated with 5 centimeters of water, 5 centimeters water PEEP. The pressure support during NIV was 7.5 centimeters of water. That means that peak inspiratory pressure was at least 13 centimeters of water to reach a tidal volume of 10.6 milliliters per kilo, which in a normal man means a tidal volume of 742 milliliters, which divided by the compliance makes 32 centimeters of water. That is the real pressure that inflated the chest was 32 centimeters of water. And we do not see it because we think that the pressure is 13 centimeters of water. So all spontaneous breathing support systems have problems because under the right conditions, or actually under the wrong conditions, spontaneous respiratory activity might be dangerous. I say might. I'm convinced it does. First of all, as I just showed you, the transpulmonary pressure might be higher than we can observe directly. And that is because when you have, for a given tidal volume, the transpulmonary pressure is exactly the same, no matter what the airway pressure is. Moreover, when the patient makes negative intrathoracic pressure, that might generate directly pulmonary edema, particularly in patients with doubtful cardiac function. This is a very famous slide from François Lemaire, 1988. Very nice paper, you should go and read it. And last but not least, alveolar pressure is very important. This is, you see the alveolar pressure during controlled mechanical ventilation. And obviously, during controlled mechanical ventilation, the patient does not expand the chest with his muscles, and the alveolar pressure is always higher than PEEP. But when you put pressure support, and you go from pressure support to CPAP, the lower the support, the higher the effort of the patient, and now the alveolar pressure might even get to negative values, contributing to alveolar edema and interstitial edema. So the main difference between controlled breath and spontaneous breath is that in spontaneous breath, the alveolar pressure is lower than PEEP, while in controlled mechanical ventilation, the alveolar pressure is always higher than PEEP. And this is, again, a very famous slide with mild lung injury in animals, mild lung injury. Spontaneous breathing is better, But with severe lung injury, spontaneous breathing contributes to the damage and makes the damage worse. So we believe really that there is such a thing as patient self-inflicted lung injury generated by a very high respiratory drive and very low mechanical properties of the respiratory system that contributes to edema and interstitial lung edema, generating a vicious circle that increases the respiratory drive, which increases the negative pressure, which increases the edema. So in acute hypoxemic respiratory failure, pressures are hidden, and you should keep really a close look on what is going on with your patient's mechanics. Thank you very much.
Thank you, Antonio. Thank you for an excellent talk. Lise will now introduce our next speaker.
I have now the pleasure to introduce Professor Massimo Antonelli, who works as an intensivist, is Professor of Intensive Care and Anesthesiology, and Director of the Department of Emergency Intensive Care Medicine and Anesthesiology of the Fondazione Policlinico a Roma. He is also a famous researcher in the field of acute respiratory failure and is one of the EASY ICM past president. You can go on with your presentation, Massimo. For the moment, we don't see your slides. Wonderful. They are here now.
Yeah. Thank you. Sorry for that.
Everything is okay.
Good afternoon, ladies and gentlemen. Can you hear me now? Okay. I would say that this afternoon I have to focus on a slippery slope. I have to move on a slippery slope because I have the task of speaking about the framing the appropriate control group for future trials. I'm quite convinced that the way in which I prepare my presentation that I may delude some of the audience. However, I will try my best. And I will leave to the discussion some of the reflections and objections that I have concerning the presentation of my the previous two speakers and good friends. These are my conflict of interest. Well, when we speak about, generally speaking, maybe my presentation may be more philosophical than factual regarding specific target or measurements. But when we speak about control groups, we mean that we are using a control groups that allow us to compare between a group of people that does the training, then the experimental group, and a group that does not do the training or the trial, but may instead do a different activity. And this is the control group. And the comparison between the two can give us the answer on the effectiveness of a certain treatment, for example. Well, but I want to focus and draw your attention on the intrinsic problems that are behind the choose of a control group. And these problems concern the blinding, the context, the need of having a stringent inclusion and exclusion criteria, the standardization of the methodology, the need of having at times, in order to replicate efficiently at the bedside, a pragmatic approach. And we have to consider also the evolving design of the more modern trials. What about blinding? I put here a study which is far away from our subject, simply because I want to stress how at times the blinding may be obsessive. In this paper, where the hemoperfusion through polymyxin B filter in order to treat septic shock patients has been investigated, for the sham treatment, there were a number of solutions that were indeed very peculiar. A hemodialysis machine prime at the bedside, a standard blood line and dialyzer in order to mimic the real situation also for the control group. A dialysis catheter was cut to simulate the insertion and taped over the skin beneath an opaque dressing. So this kind of approach is indeed very precise, very careful, but on the other hand, very, very unpractical and very obsessive. I repeat this. But well, when we speak about non-invasive ventilation, for instance, whatever the interface we are analyzing, or oxygen therapy, blinding is not possible. So this is the first step. We cannot use blinding of our population. I want to remind you the narrative review that has been recently published into the intensive care medicine, and where, looking at this cartoon, for example, you may receive some indication how to choose in the right context the various populations and the control group, delineating, for instance, a different severity and a different population to take to enroll in the study, and also the evaluation of certain parameters, such as the most simple one as the PaO2 FeO2, assessing various targets in order to answer our questions. But I want to precisely explain what the content means and how important may be the inclusion and exclusion criteria, as well as the standardization and the pragmatic approach. This study, for instance, has been published a few years ago, characterized a specific population where the high flow oxygen therapy was compared to the conventional oxygen therapy in order to treat those patients who developed after the extubation an acute respiratory failure. And if we look at the eligibility of the patients, always you have to consider that these patients should have passed a spontaneous breathing trial, and their PF was below 300. But there are also specific things. We are speaking a population just after about the extubation, and the FeO2 set was adjusted in both groups in order to obtain a specific target, which is 92% or 98%. And we have always also to consider a time frame. The Venturi mask and then nasal high flow cannula were applied for 48 hours or up to ICU discharge. I want also to mention this other study, which is very popular and published into New England Journals of Medicine by the French network, whose coordinator and first author of this paper was Jean-Pierre Frat. There, after having checked more than 4,000 patients, ultimately this group of researchers randomized 106 patients receiving high-flow oxygen group, 96 assigned to receiving standard oxygen group, and 111 to receive non-invasive ventilation. As you may know, this trial was largely in favor of the use of high-flow nasal cannula. But once again, look at what the researchers have done. They have selected a population which was always older, adult patients with specific criteria, with a respiratory rate above 25 and the PF below 300 or less, while breathing oxygen at a flow rate of 10 liters per minute, and for more than 15 minutes. But there is a but. The authors were so precise in order to have a reliable measurement of FeO2, they use a portable oxygen analyzer that was introduced in a non-rebreathing face mask. It is obvious that this is a very precise procedure, but on the other hand, it is out of the real clinical life, and never out of this specific context you may mimic a similar situation in the real life. However, also in this study, were fundamental just identifying the main exclusion criteria. And for instance, in this case, were those patients whose CO2 was hypoxemic pulmonary edema or neutropenia, or were with the mental obtunded or in coma. But one point in this study that jeopardized, at least in part, the final conclusion, was that non-invasive ventilation, for instance, was applied intermittently and without a standardized protocol. And the balanced experience of the centers involved was not the same, which means that the standardization, of course, may be really important. And also the way in which non-invasive ventilation in this study was applied, being intermittent, may have, in a way or another, conditioned the final results, alterning moment of recruitment and de-recruitment. It is with great pleasure now that I want to illustrate this study that has been published just 1 hour ago in the JAMA, coming from our group and other Italian investigators, where we compare the helmet non-invasive ventilation in pressure support versus high-flow nasal oxygen, addressing the days free of respiratory support in patients with COVID-19. The final conclusion and relevance of this paper was that both helmets and non-invasive ventilation, when they were compared each other, resulting in no significant difference in the number of days free of respiratory support within 20 days. So substantially from the main outcome of the study, a negative study. But on the other hand, as a secondary outcome, we could demonstrate that there was a clear-cut reduction of the cumulative incidence of intubation in those patients who were receiving helmet non-invasive ventilation in pressure support in comparison to high-flow nasal oxygen. Well, once again, the context here is very important. If we want to choose appropriately the groups of investigation, you have to define a clear-cut perimeter. In this case, the eligibility inclusion were stringently applied to an early phase of the acute respiratory failure within the first 24 hours from intensive care unit admission. And, for instance, differently from the FRAT study, we couldn't use an oxygen analyzer in order to determine a precise FiO2, but a nominal FiO2 that was between 24 and 60 in order to set the system as in the real life with a pragmatic approach applicable anytime at the bedside with this situation. Then all the patients were enrolled if all the inclusion criteria were fulfilled. And we are speaking about severe patients with a PaCO2 below 45 millimeters of mercury. But the methodology, the standardization is absolutely important in this case. And for this reason, careful indication that should be replicated in any study when we want to standardize the procedure were precisely defined for the high-flow oxygen therapy, including the duration of that for enrolling the patient. And also careful criteria for winning from the high-flow oxygen therapy from the helmet non-invasive ventilation were fixed. And in the same paper, just in order to standardize, we show how the system should work and how the setup of the ventilator should go in order to offer the possibility of having precise references for the readers and the eventual future investigators. I want to conclude my presentation addressing a specific situation that regards the more recent randomized trials I'm referring to the REMA-CAP. Why this is important and in which way this can influence also the future studies concerning the mechanical ventilation. Because this study has several domains and takes into consideration the possibility that over time, certain therapies whose evidence is coming out recently and may change the attitude of the investigators, of the clinicians to apply these or that therapies, may also influence the outcome or other primary endpoints because of the presence of these domains, which means to elaborate what is in the modern time called an adaptive design, which is very complex, but it's something that we have to consider carefully for the future investigations in order to reproduce as much as we can the ongoing evidences and changing over time, as we have seen during these days, during these months, for what concerns the SARS-CoV-2 infections and RDS. Which are my conclusion then? That choosing the appropriate control group is not certainly easy. And all the different issues and items we have and important issues and are essential to plan a good control group and a good study group before to start your investigation. Thank you very much for your attention.
Thanks a lot, Massimo, for this very good presentation. Very interesting.
Thank you, Massimo. Thank you, all of you. I would like to remind all those listening in that while the slides from the presentations won't be publicly available, the presentation is recorded and everybody can come back and watch it at their convenience. So with this, I'd like to turn it over to Lise to ask some of the questions that came in on the chat during the talks.
The first question I would like to ask is whether there are objective criteria which can be used to facilitate the
There has been a problem.
Yes, so the question was, are there objective criteria for initiating non-invasive ventilation versus intubation?
I guess so. I don't know if Guillaume wants to answer this question, or Antonio.
I think the real expert is Guillaume.
I'm sorry, Antonio, I didn't hear that.
I think the real expert is Professor Carteau.
Some objective criteria to decide.
Okay, it's obviously a tough question, as you understood. There are some obvious criteria when the respiratory distress is too high. There is very high respiratory rate, very strong respiratory effort, very high level of hypoxemia. But I think that the clinical judgment is enough in this kind of cases. And what is difficult is that there is not that much publication that allowed us to isolate some clear criteria for should I try in one patient, in one specific patient, to test a non-invasive support, or should I intubate it? That's why we really need some trial in this field. But what is difficult is to indeed design the control group and to design the selection criteria. Because we have to select patients with a high risk of CD, for instance. So what is a patient with a high risk of CD? Should we select them based on respiratory effort, but this is very difficult, as you know, because to have true measurement of the respiratory effort, you need to have a nasophageal catheter, which is very difficult in the context of a clinical trial. Should we monitor the tidal volume, which is only possible during NIV, but not during high flow nasal cannula? So this is a very difficult question, and I think if nobody had the answer, this is because there is no specific answer.
Then basically we have to trust our clinical judgment. Probably is the only real answer to that. Antonio? I think that Antonio disappeared. Then maybe we can...
I do have some comments, if I can.
Yes, of course.
I would say that what Guillaume said is really essential in the sense that when we look at specific criteria, we have to remember that in the real life, we have a large gray tonality and not always black and white. I want to give you an example. For capacity reasons, during the pandemic, a lot of people has been ventilated in a non-invasive way. Why? Because there was no possibility to admit to the ICU, for example. And we have seen, each of us, that at times, people whose criteria or whose PF or tidal volume or whatever were very severe went subsequently better, ameliorated without any damage. And others that precipitated immediately needing the endotracheal intubation. So it's very difficult to individualize and finding out different criteria to look at. Ultimately, there is another important point, because both Guillaume and Antonio have shown the negative effects of the spontaneous breathing. But I guess that when we work on the pressure support, we have always to consider another effect, that the pressure support in spontaneously breathing patients may also reduce the inspirative swing. And at times, doing so may compensate the transpulmonary pressure expressed in a purely spontaneous breathing in certain subjects. Not always so, but this is an effect. And on top of that, just the lung-safe trial demonstrated that all those patients who had a spontaneous breathing died less, whatever would be their severity, respect to those who indeed received the fully mechanical ventilation. So I simply said that there are a number of apparently mathematical, physiological consequent situations, but I say that a lot of individual differences may have an important role.
And there is another question that is related to this topic. Someone asked whether we have solutions to reduce the risk of PSILI in those spontaneously breathing patients, maybe using opioids or modulating the pressure support level, or maybe very low dose of neuromuscular blockers. What do you think about that? Yes, Antonio?
Well, there are at least two solutions. Tentative. One is sedation, not always effective. The other one is very experimental, bit rough, proposed by Leo Hanks, which is partial curarization. But the application of that is really difficult and limited to specific situation. That is very high respiratory drive without an equivalent decrease in PO2 or increase in PCO2, because you have to maintain blood gases anyway. So I think what one has to do is to monitor the effort and monitor and have a good idea of the transpulmonary pressure, because the most important determinant of the possible damage, if it does exist, and I believe it does exist, is transpulmonary pressure, be it generated by the muscles, and there the muscles might be damaged too by overload, or by the ventilator. It doesn't matter. If you apply 50 centimeters of water, they can be done either by muscles or machines, but it's always 50 centimeters of water. So for a given compliance, a given tidal volume requires a given pressure.
And this answers to another question we have received. And the question was, is there an indication for using esophageal pressure measurement in those patients? I think that you have answered yes. But for transpulmonary pressure, do you agree?
It depends. If you have 100 patients in CPAP in the hospital because you have COVID-19 pandemic, I doubt you find 100 balloons in the hospital.
That's reality, yeah.
Yeah. And in adjunction to that, it's not so easy to apply the NG tube for measuring the transpulmonary pressure in all patients.
Agree.
And there is also another interesting question. Someone asks whether we should put our patients under NIV or CPAP in prone position to try to reduce PSILI.
It has been done. It has been done. It has been done very frequently during this pandemic, at least in northern Italy, probably all over Italy, and I guess it has been done in France too. Yes. But the mechanics and PO2 and blood gases of these COVID-19 patients have some specificity that makes them sometimes slightly different from the usual RBS patients. Is this concept of the so-called happy hypoxemia. I don't know whether it exists or not, but I have the impression that these patients sometimes get to very high respiratory drive quite late. But I have no data. It's just,
Daniel, have you got a question to ask or something to add, maybe?
Well, I will say that the prone positioning and non-invasive ventilation has been used extensively in the US and in our hospital, and we've definitely seen patients benefit from it, but I don't think anybody has actually measured pulmonary mechanics during that situation to tell what the physiologic effect is. I think though that we are out of time for more questions. So I'm going to thank the three speakers. I'm going to thank the audience, and I'm going to remind people that these seminars are an incredibly effective way for us all to remain in touch in this awful time and discuss issues which are very relevant to the treatment of COVID-19. So I'd like to thank the European Society for organizing this seminar series. So, Lise, would you like to have the final word?
I would also like to thank you, everyone, for this wonderful session and give you some courage for the next weeks in our ICUs.
Yes.
See you soon.
Thank you, Lise. Thank you, Daniel.
Thank you, all good friends. Bye.
Thank you.
Bye. Stay safe.